So thank you, Radhika, for your invitation. We have been working together for years now in different countries, doing a lot of training, MVA, medical abortion and contraception. So thanks to ask me to present France as a golden model. Nobody's perfect, so of course we're not perfect, and it's not totally a golden model. And even if from inside I can see what does not work so well in my country as I would like, our experience is maybe interesting to share. So I will try to tell you, I will try to shorten a little bit because I know that we are late. Legal context and how the law has been revised and used at its almost full extent, some data, what was and is a strategy to improve access and acceptability on medical abortion, and what is good in the golden model and what is less golden, let's say. So 67 first contraception law and 75 first abortion law. So abortion is on demand of the woman. It's not the doctor who gives the authorization, but the woman asks for an abortion and she must have it. And but very quickly the law appears not to be adopted and too restrictive. But it took 25 years and the commercialization of mifepristone for the government to accept to vote a new law. So that was not also a golden government, we'll say. So 2001, the new contraception and abortion law, it's abortion is authorized up to 14 weeks LMP. Second trimester abortion is authorized only on medical grounds, which means that psychosocial indications are not taken into account, and sometimes it's very difficult to get an abortion for a woman at the second trimester abortion. So something which is not golden also is that we have 2,000 women going in Netherlands, UK or Spain to get a second trimester abortion. And we are I think it's very, very bad. So something which changed from the first law is that parental authorization for minor is not anymore mandatory. No more mandatory women counseling before abortion. Male and female sterilization authorized with no condition of age and number of children. And last but not least, possibility of medical abortion outside of hospital structure. In private office and after in primary care center. Between 2013 and 2015, it was a very good political context for women and a lot of good improvement. Reimbursement of abortion up to 100%. To be in a distress situation to get an abortion has been erased in the law. It's a symbolic measure, but it's important. So the woman doesn't have to cry or to justify for the abortion. Also contraception, all methods, is free of charge in private practice for minors between 15 to 18 years old. It was possible before, but only in family planning center. And also the last modification, but important, no more waiting period before an abortion, which is very good for medical abortion because we can do it very early. And midwives are now authorized to perform medical abortion. Since 2009, they are authorized to give contraception, any contraception, IUD, pills, but now it's medical abortion. Some data, so we have a very high contraceptive prevalence, and pill is still the preferred method in France. Even it seems 2010, we note a downward trend of this method, partially compensated with the use of IUD and a little bit of implants. Prevalence of IUD is 24%. We try to train professionals and tell them that even to newly parents girl, nulliparous women, IUD is good, but it's a little bit sometimes difficult to make that understand. Condom use is increasing, especially with young people. And another not golden part of our model, sterilization very stable and very low, especially for men. Almost no male sterilization in France. So regarding contraception and age, as usually I think, pill when you are young and decreasing with the age, IUD not so much when you are young and increasing with age. And so emergency contraception, very good access and largely used. Levonorgestrel and ulipristal is OTC for years now and can be reimbursed with a prescription. And for minors, since 2001, it's free of charge and OTC in pharmacy and can be delivered by school nurse at school and in family planning center. So it's really largely used, especially for young girls. Unplanned pregnancy and abortion. There is a decrease in our country, as almost everywhere, of unplanned pregnancy rate, but more frequent recourse to abortion when the pregnancy is unplanned now. 1/3 of unplanned pregnancy are linked to no use of contraception and 46% of misuse. There are a lot of forgotten pills. Because we are using a lot of pills, there are a lot of forgotten pills too, of course. And something that you can see in a lot of papers is that expanding access of emergency contraception had not a major impact on reducing the rate of unplanned pregnancy, primarily because the incidence of unprotected intercourse is high, and also because it's moderately effective. It's not as effective as we hoped, and it's not used often enough. But it doesn't mean that it's not good, because all papers show that women who use emergency contraceptive pills are subsequently likely to adopt more effective contraception. So that's the rate of abortion rate, and since 1990, the abortion rate is completely stable. It doesn't move, it doesn't increase, but it doesn't decrease. So we usually say that we have the French paradox. We have a high contraceptive prevalence, a high prevalence of medicalized methods, which means efficient method, a good access to emergency contraception, and no decrease in abortion rates. I will say something in my conclusion about that. So service delivery. So there was, of course, so you know that France was the first country to commercialize medical abortion. So surgical abortion is decreasing now, and almost 2/3 of all abortion are medical abortion, mostly done in hospital, and for almost 20% done outside of hospital structure. So who provide contraception and abortion services and where? So private and public hospitals, surgical abortion up to 14 weeks LMP. It's only aspiration. We are not doing any more sharp curettage for a long time now. Medical abortion possible up to 9 weeks at the hospital. All methods of contraception and sterilization available at the hospital. In the office, private office of doctors and private office of midwives, medical abortion is authorized up to 7 weeks LMP, and all methods of contraception. In primary care center and family planning center, medical abortion is authorized up to 7 weeks LMP. And so it's not yet in practice, but now in the law it's possible to do early surgical abortion, but it's not done yet. And of course all methods of contraception. And something which is very good is that pharmacists and nurses are authorized to prescribe pills for 6 months more when the prescription is over. So it's very good. When the girl doesn't have time to go to the doctor, they can have anyway their prescription. Sometimes the pharmacists do not know that it's possible, but it works anyway. It works, not too bad. So cost of contraception, well, I will try to go a little bit shorter. So contraception, something which is, I think, important. Contraception is always proposed and prescribed by the provider the day of abortion. I mean, the provider of the abortion is the same as the provider of the contraception. It's not true in the other way. I mean, some providers are doing contraception and not abortion, but doctors doing abortion are always, and really it works in this way, always doing contraception, and this in all sites. And the prescription of pill usually is done for at least 6 months, but most of the times for 1 year, which gives time. IUD is usually inserted immediately after a surgical abortion or prescribed for the follow-up visit after medical abortion. Regarding cost of medical abortion, so drugs are not bought, are not, well, the practitioner have to buy and to pay for the drug. Women cannot go to the pharmacy and get the drugs. That's not possible. We asked for that, but the government didn't want, the Ministry of Health do not want. So it's a package fee. It's around 2,000 €, same price as surgical abortion. So the price of an abortion, it's not because it's less cheap or not that you will choose one abortion and another one. So it's almost the same price, and anyway, it's reimbursed 100%. And in most private structures, women pay a flat rate of almost 200 € for medical abortion, the cost being later fully reimbursed by the National Health Insurance System. In public hospital, primary care center and family planning center, and some doctors who accept the deal, no advance payment is required, the cost being directly charged to the National Health Insurance System. So, moving services away from hospital base was our strategy, because the 2001 law has given the possibility for doctors and midwives to provide medical abortion up to 7 weeks, but there is a condition. The condition that they have to be part of a network and connected to an affiliated hospital to deal with eventual complication. A contract has to be signed between hospital and practitioner with duties and responsibility for each partner. For the practitioner, he has to respect the abortion law, give all the information. An informed consent has to be signed by the woman. An information sheet is given with the complication, how it will go, and address and phone of the reference hospital. Of course, she can go in any hospital, but usually we choose the reference hospital close to the women's home. So the doctor has to fill out a medical file with a copy given to the patient in case she's going to the emergency room, and send, theoretically, he has to send to the hospital the final result after the follow-up visit. I can tell you that it's never done, because you have a lot of follow-up visit. Yeah, they don't come at the follow-up visit, and even if it's in the law, nobody is doing it anymore. So you can forget it. For the reference hospital has to treat any resulting complication 24 hours a day, which is not a problem, because usually it's always an obstetric facility, and of course including women with ongoing pregnancy and retentions. And they have also to train the provider, theoretically. Sometimes they are doing it, sometimes they are not. And there is an outline. I was at the head of an abortion center, I was at the head of the reference hospital, and I was the hotline. But it's not done, it depends of the hospital. Protocol, so this is still the official protocol. 3 tablets mifepristone, 2 tablets orally of misoprostol. It's still the one officially, but with the French National College of OBGYN, we designed new recommendation in 2000, 2016, so 2 years ago, and the recommended regimen by the college is 1 tablet of mifepristone, 24 to 48 hours later, 3 or 4 tablets of misoprostol, then a follow-up visit. I don't have official data about who is using official protocol and who is using recommended protocol, but it's probably something like 50-50. Which kind of testing do we have to do? Group test and rhesus is mandatory because we are doing anti-day vaccine for women negative rhesus. I know it's not useful, but anyway, we are doing it. Ultrasound is recommended to date the pregnancy, but it's not mandatory, but everybody is doing it. Other test is only if needed, and usually we don't ask for anything else if the woman is in good health. For the follow-up visit, theoretically, nothing is mandatory, but qualitative HCG testing is recommended 2 weeks after the medication, but ultrasound is anyway largely used. All these tests are reimbursed 100% if you put something on the prescription saying that it's an abortion. So the strategy to improve access and acceptability of medical abortion has been to make medical abortion available in different sites, because backup services in case of complication are easily available, and you know that anyway there are not a lot of complication and it's very secure, medical abortion as surgical abortion. And I think to have different sites meets the needs of the patient. They can go to the hospital for when they need and feel reassured to stay few hours at the hospital. It's sometimes more anonymous, and it's easier and more secure for the more complicated cases. But they can go to private office or primary care center when they need a more personalized care, close to home and faster, because it is faster. Also, what we think was good is to have different providers, OBGYN, GPs and midwives. First, we are facing a sharply decreasing number of OBGYN, and they are still reluctant to perform abortion, especially medical abortion. They don't like medical abortion usually. And GPs are close to family as well as midwives also. Women most often come first to their GPs when they are pregnant, whatever may be the decision to keep or not the pregnancy. It's a fast-track support when advice is needed or question arise, and it's a procedure very easily to learn. And the result is that because we train a lot of GPs, 65% of medical abortion done outside of hospital structure are performed by GPs. Only 3% by midwives, but it's because it's quite recent. It will be increasing a lot. So, to conclude, also we create association in some regions funded by Ministry of Health to help the reference hospital to create their local network by providing logistic support such as model of all the paperwork needed. And the picture of access to medical abortion is somewhat mixed. In some regions where doctors and midwives have been trained, the rate of medical abortion performed in private practices is quite high. In other regions, lacking the appropriate training of personnel and with no identified resource professional, women have to go to the hospital. They don't have the choice. From our experience, the development of medical abortion is directly linked to the implementation of training program. You can think that network, as defined in the law in France, is an extremely structured and rigid framework, but the advantage in practice is that it is also very reassuring and doctors felt more comfortable. I think if we succeed in training so many general practitioners, it's because of its structure. I know that I think it is a little bit rigid, but it has been very helpful. So, to conclude, the stability of abortion rate shows that despite the high level of contraception use, the control of fertility seems to remain problematic, and the perfect control of fertility is difficult on the long term, even with a golden model, and I think we have to accept that, and also probably to accept that abortion is also a method of contraception. Thank you.
Разрешите поблагодарить от вашего и нашего имени Даниэла за столь подробное и очень практичное изложение проблемы. И спросить, есть ли у вас вопросы, пожалуйста. Да, конечно.
Спасибо. Я хотела... Да, этот вопрос перешел из прошлой сессии на эту сессию. У меня вопрос по поводу...
Я прошу прощения, можно представляться?
Гульнара Рзаева, Азербайджан. Я хотела поинтересоваться вопросом проведения медикаментозного аборта со стороны среднего медперсонала. Если мы, с медикаментозным как-то более понятно, если мы проводим им обучение, они консультируют, выдают эти таблетки и так далее. Но мы знаем, что существует определенно, около 2% процент, когда аборт не происходит и беременность продолжается. Имеют ли право они на дальнейшее ведение данной женщины, или у вас существует какой-то договор с другими клиниками, где происходит прерывание беременности, вакуум аспирации? Спасибо.
For midwife and for doctors, exactly the same structure. So they have to sign the contract with a reference hospital. And, we don't have a lot of midwives now because it's the very beginning of the system authorizing midwives to give medical abortion. But what I can say and what we know is that whatever the structure where medical abortion is done, there's no more complication in private practice than in hospital. Exactly the same rate of complication. And we think that for the midwife, it will be the same because they are doing the same training as the doctor. Exactly the same training. They are really good. I mean, they know how to do. As well as the doctors. And probably better than the OBGYN. Oh, if they have complication, well, first they go to the reference hospital if the hospital is closed. But they can go in any hospital, anyway. They will be taken, the same way. Yeah.
Можно я сама добавлю одну вещь, если разрешите? Очень кратко. Меня не втерпешь. Я просто хочу, как акушер-гинеколог, долго работающий в больнице, но сейчас я работаю в НГО, которая занимается репродуктивным правом. Я хочу добавить, что ситуация с мидвайф и медсестрами, со средним персоналом в Европе, в Америке, допустим, и в бывшем Советском Союзе разная. Поэтому я, например, как специалист, категорически против, имею это право сказать, чтобы вот это дело поручить среднему медперсоналу.
Пожалуйста, вопрос. Пожалуйста.
Казахстан. Я хочу задать вопрос Даниэлю. Вот вы говорите, что средний персонал имеет право делать медикаментозные аборты, да? Достаточно ли обучить средний персонал и дать им сертификат, и они, возможно, это будут делать? Или необходимо все-таки какое-то разрешение со стороны ассоциации или общества акушер-гинекологов?
I mean, your question about what things the OBGYN? What?
About how midwife will be interviewed in medication on abort. Do you have the right License without an OBGYN.
Yeah, they don't need OBGYN to do that. I mean, they are completely autonomous about these things. Same for contraception. They don't need OBGYN. Well, what I can say is that sometimes OBGYN are very much against the fact that midwives are doing medical abortion. It happens sometimes. But you know, it's exactly, midwives, it's exactly like a doctor. They have the same right to do. It's not what we call a paramedical profession. It's a medical profession. They have 5 years training before being midwives, and they are very well trained. It's in medical school. I mean, so they are really good. I mean, their level is really good. They are doing a lot of things. They are also allowed to do ultrasound, even antenatal ultrasound. So they are really good.
Пожалуйста.
Well, I live in another world that is different than this region, but I can tell you, my wife is a general practitioner, doesn't work in a hospital, and provide safe abortion both by manual backward aspiration and medical abortion, and doesn't need a hospital. I mean, if the medical abortion doesn't work, she does a manual backward aspiration outpatient without a hospital. And no problem. I mean, she has been working for 20, 30 years with no problem. So you don't, I agree. Well, I have been a professor of obstetric for decades, and I realize how resistant obstetricians and gynecologists are to accept that other non-specialists can provide abortion. But the reality is that you don't need an obstetrician and gynecologist to provide both abortion and contraception. And there are examples, for example, in Argentina, which is a Latin American country, where obstetrician and gynecologists have been resistant to provide safe abortion according to the law, is being provided in primary health care by general practitioners and midwives, both medical abortion and manual backward aspiration in primary care facility. They don't need a hospital. This is reality, and I know that it's a different reality of your region, but this, I can assure you, that is safe, it's closer to the women, and it provides better services that if you limited it to the hospital and the specialist.
Yeah.
Another question.
Yeah.
Why the limit of 7 weeks and not 9 weeks as WHO and FIGO recommend?
Why is the limit of 7 weeks? I don't know. It's completely, c'est arbitraire. I don't know why 7 weeks. It could be 9 weeks, you know, but because it was in 2001, I think government was afraid. We fight a lot to get medical abortion outside of hospital structure, but they were afraid. So we asked for 9 weeks, but they don't want. So I think the next step it is now. The two next step is to fight for 9 weeks and not 7 weeks. Yes, and the next step for midwife, and they are trying to get that, is to get surgical abortion, at least early surgical abortion. But now it's not yet possible, but it will be possible in a few years. It will be.
Спасибо. Извините, у нас вот последний стол первый, потом здесь.
Thank you very much for this presentation. I just wanted just your reflection on this French paradox that you just mentioned. You said that with the increase in uptake of modern methods, there is no decrease in abortion. And you also, in the end, correct me if I'm wrong, you said that it's because abortion is used for family planning reasons. But I myself, I see it from a different perspective, because you also mentioned that the unmet need for family planning is low, and the basically those who want to use modern contraception, they're using it. So for me, it's kind of a situation of equilibrium. Those who want to get access to modern contraception, they're actually getting it. Those who want to get access to medical abortion, they are getting it as well. That's why over the time, you don't see this trajectory of the decrease in method of abortion with the increase in uptake of family planning. And if this is the case, then maybe we may see countries who actually satisfy the access to modern contraception and to abortions, whatever methods they're going to use. Then we can use those countries as a reference. And based during the previous session, we also discussed the data, right? And my second question, while you will be also answering to this French paradox and how also it used in different countries, I assume that there is also other countries who will be facing this French paradox. Some of the data is collected from the private sector, as well as if it's over the counter, then that will be collected also from the pharmacies. How well in France, and if you know also in other countries, those over-the-counter pills, which also is going to contribute to the youth of abortions and to the youth of contraception and services, right, is going to be taken into consideration to get the full picture of those, and whether this is going to be a confounding factor at all to underestimating or to overestimating the overall picture for it. Thank you very much.
Well, you mean for abortion, data from abortion? Mainly contraception and abortion. Okay. For abortion, we have quite a good picture because we have different way, because it's reimbursed, we have different way to know how many abortions are done. It's because of the reimbursement, because we don't have the same system as before. Before, for every abortion, we have to fill something, and there was an underestimate rate of abortion. But now, because of the reimbursement, we know exactly, almost exactly, the number of abortion. Regarding contraception, it's not the same. It's much more difficult. And the data I gave you is from study, from survey. And it's not from companies, it's national research survey. So, and I think it's a good picture. Of course, it probably underestimates, but it's quite a good picture of the situation in our country. And I think this good picture, we can have it almost in Western Europe, but Marge, you can say that better than me. And we know, and we have good data. And regarding the French paradox, I think that we have to accept that we will not go down with the rate of abortion. It's like that. We know that in France, from surveys, that some women are not doing any more abortion, but some women are doing more than one abortion. So there is a kind of woman who is clearly using abortion as a contraception. So, and this is to accept.
Можно попросить, чтобы были бы не выступления, а вопросы, потому что у нас время очень ограниченное, мы не укладываемся, поэтому, пожалуйста, если у вас есть вопросы, задавайте конкретные вопросы. И еще мы имеем право еще на 2 вопроса дополнительных. Спасибо.
Okay, so, sorry, mine wasn't a specific question, it was a response to Professor Fonda's and about task sharing. Within SAF, we support a lot of countries, and particularly in Sub-Saharan Africa and Southeast Asia, you have a large number of mid-level providers that are available and a shortage of doctors. So we have a lot of experience in terms of increasing access to safe abortion services with mid-level providers. So to the point, I'm not sure what the lady's name was, about complication rates, it's not an issue. what you need is a trained provider. And we have an example in Nepal where the government have actually partnered with one of our grantees to increase access to safe abortion services by training auxiliary nurse midwives in rural areas where there was an issue with high levels of unsafe abortion due to lack of access to safe abortion services. And as a result of that, there's been a decrease in the number of complications and a decrease in the number of women accessing unsafe abortions. So ultimately it comes down to training and ability. And that is something that can be worked on with effective quality assured training programs. So it's not by whether you're a doctor or you're a nurse or a midwife, it's about the training that you've had. So just to say that, just to quell any issues that people might have.
Okay, quick comment. In Kyrgyzstan, in the research that we conducted there with midwives, the midwives were excellent at providing medical abortion, reaching nearly 98% effectiveness in the whole sample of over 500 women. Question to Danielle. So abortion is free, it's reimbursed rather. How much does government reimburse the clinics that provide the service?
Same price?
No, but what is the price? The cost of the package, 187 euros for, okay. All right.
It's not a lot. Doctors are complaining about that. You can imagine. Because, you know, when the woman pay or the government pay 200 euros, it means that almost 100 euros is for the drugs, for the pills, the Myfe and Myzo. So it means 100 euros for the doctors, which is not a lot. So they are complaining about that. They are complaining.
So this is an issue in Ireland right now. It's going to be given free to women, but the GPs, the government's just said they'll be reimbursed 400 euros per abortion. So that's what they think they have to do to provide the incentive for the GPs who are very busy to provide this service.
Sorry, Suzanne, it's not a simple question, never from me, but just to say that medical abortion does not succeed because of the skill level or the cadre of profession of the provider. Medical abortion succeeds in the woman's body because the pills are effective. So the fact that it's a midwife handing you pills instead of a gynecologist does not matter at all. Whether they make it safe, it matters, but that's another question.
It's not depending on the skill.
The skill, they don't perform abortions with medical abortion pills. And that's a very important distinction to make. Secondly, WHO has not recommended routine ultrasound related to abortion for a very, very long time. Not before, and certainly not after.
Certainly not after.
Certainly not after. Third of all, the U.S. Food and Drug Administration permits abortion pill use at home up to 10 weeks, LMP, and it took Genuity and others in the United States at least 3 years to convince them to accept 10 weeks, not 7, not 9, and hopefully we can push that up to 11. So let's not underestimate that. Right? Okay. Those were my comments.
Thank you.